this happens all the time to me, that I have somebody come in and the nephrologist sent them over, or the cardiologist sent them over, or maybe the primary care doctor, and they really don't know why they're here. But she said both her kidney doctor and her heart doctor said, you should be evaluated. She sleeps 5 to 6 hours a night. She often takes naps in front of the television during the day. Her husband says that she will doze off, but she says that she does not nap and she's not tired. And I am not kidding you. I am not kidding you. You guys laugh at that. I swear that and then they get into an argument right in front of me. This happens. Okay, she's got diabetes, she's got hypertension, she's got chronic kidney disease, she has coronary artery disease, congestive heart failure, hyperlipidemia, she's overweight, and she's got chronic leg edema. She's on lisinopril, metoprolol, furosemide, aspirin, Lipitor, and insulin. She's retired secretary, executive secretary, doesn't drink alcohol, doesn't exercise regularly. She only drinks decaffeinated coffees. No tobacco in 20 years, but she did smoke previously. Her blood pressure is okay. BMI is elevated, 34.4, above that 30 mark. And I'm pointing out to you, her O2 sat on room air is 94%. Normal O2 sat on room air is 95 to 100%, right? So I put in 94 on purpose because that's not normal. 94% is not normal. And when I see that, I go, does she have some sort of underlying lung disease that I should be paying attention to also? Her neck circumference is 16.5, so 16 inches for a woman, remember? Mallampati score is 2. She's got a small posterior pharynx. She's got the central obesity. She's got a big belly. She's got scant end expiratory wheezes on her lung exam. She's got bilateral pitting edema, and she's got the indurated kind of darkened skin. Her diagnostic polysomnogram showed an apnea-hypopnea index of 67.2 per hour, 1 a minute. I'm not sleepy. I don't fall asleep. That's what she says. She had low oxygen level of 70%. There were 3 hours and 34 minutes that her O2 sats were less than 89%. She has severe obstructive and central sleep apneas. Treatment, I put her on CPAP, and actually her sleep apnea got worse. So she's going to fall into this complex sleep apnea category. So complex sleep apnea, by definition, is if you have somebody who has run-of-the-mill obstructive sleep apnea, you put them on CPAP and everything gets worse. Specifically, a lot of these central apneas come out. That is complex sleep apnea. So we put her on, there are different forms of bilevel therapy, adaptive servoventilation and spontaneously timed ventilation. And we use those 2 modes to treat the complex sleep apnea patients. And she actually did pretty well on the adaptive servoventilation. This is what her study looked like. She had that Cheyne-Stokes respiration, which is the crescendo, decrescendo breathing pattern with then periods of apnea. And then crescendo, decrescendo periods of apnea. So, teaching points to this case. Number 1, diabetes, obesity, and sleep apnea. There was a study done that found, study done in 2009, that found that 85% of patients who are diabetics had an apnea-hypopnea index greater than 5. 64% had an apnea-hypopnea index greater than 15. I think that's pretty big. You know, most diabetic patients, at least 50% of diabetic patients have sleep apnea, and we're missing it. We're not testing them. They're not telling us they're sleepy. They're women. They're definitely not telling us they're sleepy. You know, we're not sleepy. Women aren't sleepy. We just keep moving, right? We just keep moving. Chronic kidney disease. In this study, it showed that almost 50% of chronic kidney disease and end-stage renal disease patients have sleep apnea. And interestingly, sleep apnea may accelerate the decline of the kidney and increase their risk for atherosclerotic disease. I'm seeing a lot of my kidney doctors referring over to me for sleep studies. COPD stands for, as you all know, chronic obstructive pulmonary disease. So it's somebody who either smokes or has a history of smoking. And in general, I use a general rule of thumb of if you have a 20-pack year history of smoking over the course of your lifetime, that can set you up for emphysema or lung cancer later in life, even if you've quit smoking. unfortunately. So if you're a smoker, you're at a higher risk for lung cancer, emphysema, strokes, and heart attack. If you quit smoking, your stroke and your heart attack risk go way down to the like normal population. But your lung cancer and your emphysema risk is still a little elevated. And if you've logged in more than a 20-pack year history of smoking, which is 1 pack a day for 20 years, or a half a pack a day for 40 years, or 2 packs a day for 10 years, then you're over that 20-year. Now again, I don't think there's literature, but that's me as a lung doctor. I use that 20-year as a cutoff. So she had 32 years. So I point that out because her room air sat was 94%. And it is not uncommon that I will see low oxygen levels in these patients at nighttime. So she had well over 3 hours that she had low oxygen levels, right? There is an overlap syndrome between COPD and OSA, obstructive sleep apnea, and COPD. 10 to 20% of patients have both. You're more likely to develop pulmonary hypertension and right heart failure if you don't treat it. And there's an increased morbidity and mortality. So this is just percent survival. Red line here is the overlap of COPD without using CPAP for sleep apnea, and you can just see that they tend to die earlier. Heart failure. We've already talked a little bit about heart failure in that there's a higher prevalence of sleep apnea with heart failure. Interestingly, sleep apnea normally does not manifest or show itself as sleepiness. Right? My mom, 76 years old, has congestive heart failure. She's got a bad heart. She was actually here 2 years ago. She's not sleepy. She sleeps during the day and doesn't want to wear CPAP at all. She won't. I've already talked to her about it. She won't. You know, Mom, you really should. No. But that's her choice. I'm editorializing here again. So women live to about the age of 81, I'm going to say. Average age. Men, it's about 78, 79. Usually over the age of 80, I let you tell me what to do. She's not quite 80, but close. So, you know, if I have an 81-year-old, 82-year-old coming in and talk to me and they hate CPAP and they don't want to use it, I say, okay. I'm okay with that. Okay. So in heart failure, you can see more central sleep apneas and Cheyne-Stokes respiration like we saw in this case. CPAP improves the left ventricular ejection fraction, LVEF, and it improves quality of life. In general, it's not super clear yet if there's treatment of sleep apnea with CPAP will improve survival. And there are studies going on to try to see if that's true. However, there was one that published in March of this year showed that progressive improvement in systolic and diastolic abnormalities of the heart were seen in sleep apnea patients after 3 months and after 1 year of being on CPAP. So we think that there's more and more evidence to say that yes, heart function improves. LVEF, left ventricular ejection fraction, improves after being on CPAP. Treatments of central sleep apnea, you want to optimize their heart failure, send them to their cardiologist. They know all how to do that. So ACE inhibitors, beta blockers, diuretics, yada yada. Sometimes they'll get pacemakers or cardiac resynchronization therapy. Put them on CPAP or BiPAP if needed, supplemental oxygen, and then a couple other things. We'll probably use this as the last case, and it's kind of quick. AG is a 59-year-old man who presents after being hospitalized for a stroke. He was diagnosed with AFib 3 years ago, and he's had 2 prior hospitalizations for shortness of breath and lightheadedness. His INR over the last year has been 1.2 to 2.2. It should be 2, right? Should be around 2 to 2.5 or so. He underwent a DC cardioversion, shocking, right? 3 years ago, but it didn't keep him in normal sinus rhythm. And then he had an ablation done about 4 months ago, and he remains in normal sinus rhythm. But he did not remain in normal sinus rhythm. He was told he had a silent heart attack 3 years ago when the diagnosis of AFib was made. And in rehab, it was advised that he should have a sleep study done. So he says, you know, my sleep could be better. Since he's been on atrial fibrillation medications, his sleep hasn't been very good. And as a side note, beta blockers cause fatigue, they can cause nightmares, and they can cause sexual problems. So those are 3 things that beta blockers do that people don't necessarily talk about, but they can cause some tiredness, feeling just really, really tired, fatigued. Since he's been, so his sleep worsened after his wife died from breast cancer 1 year ago. He sleeps about 4 to 7 hours per night. It's not uncommon for somebody who's had a loss in the family, or a loss of a job, or a divorce to have worse sleep problems, independent of sleep apnea, but they could just have problems with sleep, insomnia. So he sleeps 4 to 7 hours a night, and he wakes usually wants to go to the bathroom. He wakes several times because of back discomfort and disturbing dreams, which can happen from the beta blocker. And he feels like his heart is racing at night, sort of when he wakes up from these dreams. He has difficulty falling back to sleep, and he normally can't sleep during the daytime. He wishes he could, but he just can't take naps. Past medical history, he's got that silent heart attack, AFib, hypertension, he had recent stroke, and he has osteoarthritis. There's lists of medicines there. Family history is non-contributory. He used to run his own construction business, but now his brother's doing it because of all his health issues. And he's living alone. And then you can see his vital signs there. His blood pressure is a little up, 142/80. BMI 27.8, so overweight but not obese. O2 sats 97% on room air. His neck circumference is 16.5. Mallampati score of 1. He has irregular heart rhythm, which goes along with his AFib. And he has some mild left-sided weakness, which actually has been improving in time with rehab. So his diagnostic polysomnogram showed an apnea-hypopnea index of 27.1, which puts him in the moderate sleep apnea category, which is severe in supine sleep, which again is not uncommon. His apnea-hypopnea index went up to 66 times an hour, so 1 a minute when he sleeps on his back. But on his sides, he was about 13 a minute. Oh, sorry, 13 an hour. Lowest oxygen level was 82%. He had AFib, so this is moderate sleep apnea. He was treated with a CPAP of 10 and actually did well. So he did well at home. The little data chip in his CPAP machine showed that his apnea-hypopnea index was 1.2, which is great. Less than 5 is what I try to get everybody to be on. His quality and quantity of sleep are much better. He's actually getting around 7 hours of sleep, maybe a little less, but around 7. He's less tired during the day, and he actually started working part-time. I know. So stroke, a little bit about stroke and arrhythmias. We all know sleep-disordered breathing, SDB, sleep-disordered breathing is a risk factor for stroke, and stroke is a risk factor for sleep-disordered breathing. We really don't know which came first, the chicken or the egg. But we know that they're related. There's an increased rate of stroke or death in patients untreated with sleep apnea, and this study showed over 4 years, but we know that from the graphs that I showed earlier, there's a higher risk of mortality if you don't treat it. There is improved long-term survival in patients who use CPAP who have had a stroke. There are studies going on right now looking at long-term markers after somebody's had a stroke and been on CPAP. I don't have the results of those studies yet, but they're looking at outcome. Turning to arrhythmias, it is very common that I see arrhythmias at nighttime when somebody's had a sleep study. And I had a gentleman who was a chef, overweight, body mass index probably around 40, and he came in to have his sleep study after canceling 15 times because he couldn't get there. His apnea-hypopnea index was about 76 per hour, and he had a sinus pause of 15 seconds. 15 seconds, sinus pause. Flat line for 15 seconds in the study. Right. Called him on the phone, didn't return me, called him on the phone again. Everybody in the office is like, ooh, Dr. Lynch, something's up. She's called this patient twice. She normally doesn't do that. So I got him in there right away. We got him on CPAP. He's doing great. He came back in tears because he feels so much better now. And I called the cardiologist and I said, does he need a pacemaker? And she said, watch him. You know, get a Holter monitor, make sure he's doing okay, make sure, you know, just monitor it a little bit, but no, we don't need to put a Holter monitor in, get him on the CPAP, get him on the right treatment. I had another guy who had third-degree heart block and sent 82-year-old gentleman, sent him right away for a pacemaker. Boom, gone. Next day, he left the lab at, I don't know, 8 o'clock in the morning, and 9 o'clock he's going to Wentworth Douglas and getting his pacemaker. So arrhythmias happen with sleep apnea. Post-op AFib is more likely in patients who have obstructive sleep apnea. I don't know if you're all aware, but many of the hospitals are establishing initiatives to learn how to recognize high-risk patients for sleep apnea and treat them prior to them having their surgical procedures. Yep. And 50% of AFib patients at cardioversion are likely to have sleep apnea. The risk of arrhythmia decreases with CPAP. If you have an atrial ablation therapy done, it can result in a decreased apnea-hypopnea index, but not to normal, if you stay in normal sinus rhythm. I actually just was on the phone today with a patient who had 50 or 60 events an hour. He has atrial fibrillation. He's undergone many trials to get him out of it, and he just underwent ablation therapy, and he doesn't want to come back in and treat his sleep apnea. My office manager talked with his wife. His wife called in today, and we're going to get him in. You know, his wife is the one who's really sort of pushing for him to get in. I'm not going to go over this case. You can actually just look at this case. It was just a fun little case to throw in there about REM behavior disorder, because it's not necessarily something that we think about, and it can be associated with Parkinson's disease. And I'm going to finish right now on a couple of slides here at the end, 2 slides here at the end. And I don't know all the changes that are happening in healthcare. There are new ones coming out every day, every week, every month, and we're all part of it. You know, we're just sort of sitting and waiting to say, okay, well, what's next, or what do we have to do next? But what I will say is that in general, patients have higher deductibles. It used to be $2,500, or it used to be $250 or $100, and then it was $500, and then it was $1,000. And I just sat down with my guy and $2,000, nothing less. They don't offer anything less. I'm a small business. I can get nothing less. My best case scenario is a $2,000 deductible. Great. So people are getting higher deductibles, higher coinsurances. Coinsurances is a new word, right? Coinsurance means that once you meet your deductible of $1,000 or $2,000 or $5,000, whatever deductible you have, they're not necessarily going to pay for it 100%. They might do 80-20. You still got to pay 20%, right? So there's higher deductibles. There are now coinsurances, and there are higher copays. It's not $5 to see a doc, unless you have a really good insurance. It's $50 now to see the doc, right? So there are incentives by many employers or health insurance companies. There are incentives to find lower cost testing places, right? And Compass, which is out in Manchester, has all of their city employees saying that if you find a low cost center to get your MRI done, or your sleep study done, or your chest x-ray done, or your labs done, we'll give you $50, right? So they're actually empowering the patient to find a lower cost place. And it's definitely to the patient's advantage to be informed. Hospital-based attended sleep studies, there are 3 fees associated with the sleep study. Same thing with an MRI, there are 3 fees. Same thing with a chest x-ray, there are 3 fees. Same thing with stress test, 3 fees. There's the hospital or facility fee. There is the technical component of the study, and then there's the physician reading component of the study. And for sleep studies, it ranges about $3,000 to $5,000. So if you have a $2,000 deductible, boom, you've met it, because you got to pay the first $2,000. Unattended sleep studies, which are the home sleep studies, are being used more now. Hospitals usually can't do it. They contract out to a facility that does do it. So it's read by potentially somebody in Iowa, who knows, but it's read by somebody else. And then it comes back. And there are all sorts of home sleep tests that are out there. Hospitals usually have slightly longer wait times. So the reason why I say this is because I'm going to tell you how I function, but I'm sure that there are other places like myself that function like this that might have lower costs. So me at the Sleep Institute of New England, there are significantly lower costs. An attended in-lab sleep study is approximately $1,000. It's not $3,000, $4,000, $5,000. This is one fee, and it's about $1,000, and that's an Anthem reimbursement. Medicare, it's about $600 or $700 reimbursement. So that, you know, Medicare is actually less. And unattended, so the home sleep study is about $250. We have our own sleep study units. We have 8 units at my office, and we mail them out to people, and they mail them back to us, and then I read them, and then get the report back to whoever ordered it. If the patient is seen in the office, then we take the ball and we run with it, you know, and if they need treatment. Advantages to coming to me: I am triple boarded in internal medicine, pulmonary medicine, and sleep medicine, and I'm trained in critical care, but I just never took my boards because I got sick of taking boards. So I didn't take that one, but I could still if I wanted to. Maybe I'll wait. When my kids get older, maybe I'll take it. I don't know. It's just too busy right now at home. The same doctor is reading the studies and managing their care. People really like that. They like coming to the sleep center. We have a mask fitting and follow-up programs. We supply equipment to most insurers so they can get their testing, they can get their treatment, their follow-ups with me, and they can get their equipment. And then we have a calling system every 3 months that if they need supplies, we just put them on, we send out calls to them, and they can get their supplies through us. And we're lower cost. And I do a lot of educating. I mean, you can probably see that within me already, is that, you know, even when I was in my fellowships and in training when I was a resident, you know, I just loved sort of teaching. You know, I would read something and then we would have a discussion about it. So I do like lecturing, I like teaching, and I often do that in the office with the patients. I offer more than sleep testing. I have pulmonary function testing and allergy testing also at the office. So, in summary, sorry, this was longer than I expected, but recognize the patients with medical illnesses that may be associated to sleep disorders. Especially the sleep apnea patients. Maybe educate the patients a little bit now that you know a little bit more. Encourage the patients to seek treatment or evaluation, and then you can also say, you know, there are lower cost options out there, and you just got to investigate where they are. So thank you.